Good afternoon to all that who have gathered here in person, as well as all who have joined online. Dr. Geetal Pereira, the president of the College of Pulmonologists of Sri Lanka, and all the other distinguished invitees. We are in the process of commencing the monthly clinical meeting organized by the Sri Lanka Medical Association in collaboration with the another professional college. Today it will be with the College of Pulmonologists of Sri Lanka. I think we have selected a topic that would be most appropriate in today's context. It would be on COVID pneumonia and pulmonary sequelae. I just can't think of another time that would be more appropriate than in today's context, as we are sort of anticipating a third wave of COVID, probably over the next 1 or 2 months. We have a very distinguished panel of experts, pulmonologists, Dr. Amita Fernando, consultant respiratory physician, Central Chest Clinic Buralla, and Dr. Afla Sadikin, again the consultant respiratory physician, Central Chest Clinic Buralla, and senior registrar. They would be joined with Dr. Lakmini Disanayaka, senior registrar, respiratory medicine, for this panel to discuss on COVID pneumonia and pulmonary sequelae. So let me invite Dr. Amita Fernando to commence the proceedings on behalf of the Sri Lanka Medical Association.
Thank you, Madam. Good afternoon for those who are present here and our online viewers and listeners. Let me thank the SLMA, its president and council, for inviting us to speak on this timely workshop on COVID pneumonia and its pulmonary sequelae. I'm also thankful to our council, Dr. Geetal Pereira, who is our incumbent president, for selecting me and my panel to speak on this occasion. To start off the proceedings, as is traditional, I will start off with a case discussion. Let me invite Dr. Lakmini Disanayaka, Senior Registrar in Respiratory Medicine, to start the proceedings.
Thank you. Good afternoon, everybody. This is my first case. Is Mr. M, 30-year-old gentleman from Colombo, who's a known patient with bronchial asthma, well controlled with inhalers, presented with fever and cough for 9 days duration, and the COVID PCR was positive on 25th March and transferred to Colombo East Base Hospital for ICU care. On admission, the patient was on face mask oxygen 10 liters per minute, and with that saturation was 92 and bilateral crepitations were noted. And on admission to the ICU, we changed the patient to high flow nasal oxygen. With that, PaO2 was 95 and PCO2 was 28 with PF ratio of 158, and patient had thrombocytopenia of 96,000 and high inflammatory markers, high CRP and elevated transaminases, and standard care of IV dexamethasone and subcut enoxaparin prophylactic dose was started. And the initial chest X-ray shows peripheral subpleural down glass opacities with airspace consolidation. And on the third day, we noted the patient was having increased requirement for oxygenation and requiring non-invasive ventilation, and the patient's PaO2 was declining to 55 with PF ratio of 263 despite of high ventilatory supports, and the patient's thrombocytopenia slightly improved, but high CRP and high transaminases was noted, and the procalcitonin level was slightly elevated. On the day 5, the patient's oxygen requirement further increased, and with NIV 0.8 FiO2, the patient's PF ratio declined up to 101, and the patient had high inflammatory markers, high ferritin of more than 1,650, high CRP, and high transaminases with normal procalcitonin levels. And at this point, we decided to give IV tocilizumab. We gave IV tocilizumab 480 milligram, that is 8 milligram per kg, first dose. And after 8 to 12 hours after, we reassessed the patient. Still, the patient's oxygenation was not improved, and we decided to go ahead with the second dose of tocilizumab. And 2 days following the tocilizumab, that is day 7 in the ICU, the patient stability in oxygen requirement was noted with FiO2 of 0.8, and PF ratio was slightly improved, 143. And the chest X-ray was similar to the previous X-ray. On the day 9, we were able to de-escalate oxygen supplementation and was able to change to high flow nasal oxygen, and the patient had increased PF ratio. And also with tocilizumab, we noted dramatic improvement in the inflammatory markers, CRP and transaminases. And in the same day, we noted patient's saturation was dropping and the patient's PaO2 was coming down, and we went ahead with CTPA. The CTPA, the main pulmonary trunks and the pulmonary trunk and the main pulmonary right and left arteries were normal, but there were subsegmental filling defects noted and suggestive of pulmonary embolism. And at this point, we changed enoxaparin to the therapeutic dose and started warfarin. At the same time, the HRCT showed ground glass opacities and peripheral consolidations with parenchymal bands of arcade pattern, and it was suggestive of COVID pneumonia with possible organizing pneumonia as well. And at this point, we decided to start oral prednisolone 1 milligram per kg as for organizing pneumonia after completing of IV dexamethasone course. The day 12, we were able to further de-escalate the oxygen supplementation, and patient was stable with high flow nasal oxygen, 0.35 FiO2, and PF ratio further increased, and inflammatory markers were declining. And the chest X-ray shows peripheral opacities were becoming denser, and despite of normal inflammatory markers, these chest X-ray changes was more suggestive of organizing pneumonia. And day 15, we were able to transfer out the patient from the ICU with venturi mask of 40%, and PF ratio was further improved and inflammatory markers were further coming down. And this is the chest X-ray. It shows some improvement than earlier. And day 21, the patient was stable on room air with saturation of 97, and PF ratio was further improved, and COVID antibodies were positive, and the patient was discharged with prednisolone and warfarin. So in summary, the patient present, this is the graph of the summary in the ICU stay, and the blue line shows the FiO2 ventilatory support needed, and the orange line shows the PaO2 of the patient, oxygenation of the patient, and the gray line shows the inflammatory markers, that is CRP. The patient present to us day 1 in type 1 respiratory failure, and the patient was started on high flow nasal oxygen, and with that also the patient, we noted decrease in oxygenation with requiring NIV support. Despite of increasing ventilatory support, the patient's oxygenation was decreasing, and at this point we decided to give tocilizumab, and timely decision of tocilizumab prevented the patient further going down and prevented mechanical ventilation. And following tocilizumab, we noted patient's oxygenation was improving, and we were able to de-escalate the oxygen support. And also the patient had high inflammatory markers with normal procalcitonin. With tocilizumab, we see the dramatic improvement in the inflammatory markers, suggesting that it was a hyperinflammatory response was there. And once the patient was improving, there was another decline of oxygenation. At that point, we have done the CTPA, which showed pulmonary embolism, and we have changed the enoxaparin prophylactic dose into therapeutic dose with warfarin. And also at the same time, we noted patient having organizing pneumonia, and we changed, we added oral prednisolone following IV dexamethasone course. With that, the patient started improving again, and we were able to de-escalate high flow nasal oxygen into venturi mask and send home. And the next two cases, I will be briefly touching about post-COVID problems we have encountered. This is Mr. Q, this 72-year-old patient with multiple comorbidities and had undergone CABG 7 years ago. The patient COVID PCR was positive March 24th, and at the same time, the patient had IgM and IgG positive for dengue, and also but had NS1 antigen negative. The patient was taken to ICU for 2 days for observation, and patients had thrombocytopenia of 96,000, which went down to 69,000, and but there was no leaking, and patient's thrombocytopenia improved subsequently. Patient did not require any form of oxygenation support, is a face mask oxygen or high flow nasal oxygen, and we did not offer dexamethasone for this patient, and patient received enoxaparin prophylactic dose. And this was the first chest x-ray taken initially on admission. The patient had bilateral peripheral ground glass changes in the mid and lower zones, and despite of clinical improvement over the next 20 days, the patient had radiologically worsening of the shadows in the x-ray, and we went ahead with a HRCT. HRCT shows ground glass opacities with peripheral consolidation and band-like consolidation with parenchymal bands of in the arcade pattern, and suggesting of organizing pneumonia, and we started him on prednisolone 1 milligram per kg. And this third case is Mr. R, 70-year-old with diabetes and hypothyroidism. COVID PCR was positive on 19 December last year, and patient required high flow nasal oxygen, and ICU stay was 7 days, and patient receives dexamethasone and also prophylactic dose of enoxaparin. Patient's initial chest x-ray was this, and even after 1 month following the discharge, the patient has persistent radiological changes and also persistent symptoms of exertional shortness of breath. And we went ahead with the HRCT. HRCT shows fibrotic bands with traction bronchiectasis and reticulation, and also some ground glass changes suggestive of NSIP and OP overlap, and we have started him on steroids, and now the patient has taken steroids for around 6 weeks, and the patient states the clinical improvements in the symptom wise as well as the radiological improvement was noted. Thank you very much.
Thank you, Lakshmi, for those introductory cases. It makes my task much more easier when I come to discussing the pulmonary sequelae of COVID-19. So my task is to walk you through these cases and see the challenges that we are facing when we are dealing with these patients. So over the past few months, Myself, Dr. Afla, Dr. Ravini, and Dr. Asha, the chest consultants at the National Hospital, have been overseeing care and working with the team at Pulmonary, our base hospital. We are grateful for the physicians there and the anesthetist and the supporting radiology, microbiology, hematology teams that work with us. So during my talk, I will go through the pulmonary manifestations of COVID-19, timelines of disease evolution, pathological correlates, because it's important in understanding the clinical decision-making process, clinical and radiological markers of the disease stages, challenges in management, discharge and follow-up strategies, and as you saw, post-COVID sequelae, or what we term long COVID syndromes. As of March, with over 117 million confirmed cases, nearly 3 million cases on a weekly basis, nearly 3 million deaths, a death toll of over 2.5 million globally, the COVID pandemic shows no signs of abating. In fact, we are facing a fourth resurgence with many countries like Germany, France, Brazil, India going into lockdown with daily tolls rising and many strains and many challenges emerging, even in spite of a vaccine program that is going on in developed countries. Many countries, including India, are experiencing, as I said, a resurgence of cases and thinking of lockdowns and other controlled public health measures. We in Sri Lanka are at 196,000, at 96,000, reaching the 100,000 mark with 618 deaths. As you know, many patients with COVID are asymptomatic or mildly symptomatic, but this may be changing. Just a few minutes ago, I saw a Facebook post which says that patients are not having many upper respiratory symptoms now, and they are presenting with breathlessness with a short incubation period. So the challenges are persisting and re-emerging, so that we have constantly to be constantly be on the alert to deal with these new challenges. Of the patients, 15% as of now will need hospital admission, with 5% needing HDO or ICU care. Those who need ICU care has variable mortality depending on centers, comorbidities, age, obesity, and other risk factors. About the morbidity in these patients, mortality in these patients are around 16 to 78%. AKI, cardiac disease, liver disease, cerebrovascular problems can contribute to mortality. The major cause of mortality and death remain the pulmonary sequelae. These include acute lung injury, adult respiratory distress syndrome, thromboembolic, and pulmonary vascular events. Our experience shows that the highest mortality are in those in the elderly, the obese, those with cardiovascular disease, diabetes, chronic renal disease, post-transplant, kidney transplant patient, malignancy, and interstitial lung disease, in particular of the chronic lung diseases. In terms of timelines, COVID has acute, medium, and medium-term manifestations and complications that occur in the first 4 weeks. Post-COVID manifestations are the persistence of these symptoms from 4 to 12 weeks, and symptoms can persist or even newly emerge after 12 weeks, which is now termed post-COVID, which is now termed long COVID. So after the acute sequelae, many, as I said, are asymptomatic. They can have a carrier stage, and as you know, they are transmissible. The virus is transmissible during the pre-symptomatic or asymptomatic phase. There is mild to moderate disease in the majority. Severe viral pneumonia with its direct cytopathic effects on the lung, giving rise to diffuse alveolar damage and resultant acute lung injury and ARDS are what we see in the acute phase. Then we see endothelial dysfunction and pulmonary vasculopathy, which leads to pulmonary hypertension and prothrombotic state, giving rise to pulmonary embolism, microemboli, as you saw in the cases illustrated by Lakmini, which can occur even late in the disease. Then there is this phenotype, the hyper-inflammatory phenotype or the immune phenotype, which can also give rise to diffuse alveolar damage or DAD and its resultant sequelae of acute lung injury and ARDS. Organizing pneumonia, and it's newly described or not what was previously considered a rare form of organizing pneumonia. Acute fibrinous organizing pneumonia is also we are also beginning to see these patients. Then secondary bacterial sepsis, mostly gram-negative organisms, but also fungal and other infections are emerging as secondary pathogens. So aspergillus, as we saw during the influenza pandemics, is also playing a significant role. Co-infection or reactivation of other atypical pathogens like Pneumocystis jirovecii, CMV are also being reported, especially in the immunocompromised patients who are on immunosuppressive medication, like the post-transplant patients. Then the long-term sequelae of COVID, the post-COVID symptoms that persist beyond 4 and last for up to 12 weeks may be limited to breathlessness, cough, fatigue, malaise, neuropsychiatric disturbances, to more serious complications like interstitial lung disease and thromboembolic phenomena. Of the interstitial lung disease, post-ARDS lung, we have seen, but irrespective of the post-ARDS changes or some changes which may due to volute trauma, barotrauma as a result of mechanical ventilation, we see the fibrotic processes progressing. And as you saw in the cases illustrated, organizing pneumonia. Also, pulmonary vasculopathy giving rise to pulmonary hypertension, chronic thromboembolic pulmonary hypertension is also being seen in patients that we have managed. So it is important to understand the chronology of events as illustrated in this graph. In terms of viremia, pulmonary manifestation, vasculopathic events to organization, recovery, or death. It is equally important to correlate these two with host innate immune response, humoral and other antibody response. Incubation periods, as I said, can last from 2 to 14 days, but average about 5 days. Viral shedding occurs during the incubation period, an asymptomatic phase. Therefore, these people are infectious. In mild disease, the immune inflammatory response is mild and runs its course over 10 to 15 days, but they may develop post-COVID sequelae. We have seen patients who are in quarantine centers and who are asymptomatic during the acute phase, presenting later with breathlessness and other problems. So you can get late sequelae, and this has no relation to the initial acute presentations. In the humoral response or the antibody response is peculiar to COVID, because what we see initially is an IgG response, and this can be present at day 2 even, and this can persist for a long period of time. So it has no correlation to your CT values or your viral loads initially. So the presence of antibody does not mean that the patient is non-infectious in the early stages. In those with severe disease, the host immune response becomes dysregulated, hyperimmune response, leading to a cascade of catastrophic consequences, which results in cytopathic injury to organ systems, microvascular changes, microthrombi, and embolic events. These can all in the lung culminate in acute lung injury, ARDS, multi-organ failure, particularly renal, liver, CNS, cardiac organs can be targeted. Profiling these patients in terms of viremic cytopathic injury, hyperinflammatory immune response, secondary sepsis, and the impact of multi-organ failure becomes critical in the decision-making process because the strategies would be different. It is also important to note that these phases may overlap, and it is not necessarily that one leads to the other. So we as clinicians must pool our expertise and our resources in identifying these processes and building up a profile of these patients so we can offer better management to these patients. The pathology plays an important role in these patients. It's of paramount importance to understanding the disease process. How we relate pathology to the clinical correlation and its biomarker profiles and radiology is important. So diffuse alveolar damage or DAD can occur any stage of the disease, and then it is characterized by pathology of alveolar damage, pneumocyte damage, and hyaline membrane formation. Then there is an aberrant repair process which may occur as early as day 7 and day 14. So here there is organizing process where the fibrin balls clog the alveoli, and this has been described as acute fibrinous organizing pneumonia. So they term the patient with COVID as happy hypoxic. The patient's perception of dyspnea and the work of breathing is not elevated when you look at how hypoxic the patient is and your blood gases. So this may be due to intra-alveolar shunting. So part of the explanation is that it may be microthrombi. The other explanation is I feel that these patients have organizing pneumonia, intra-alveolar buds, and intra-alveolar, what they call this fibrin balls, giving rise to intra-alveolar shunting and VQ mismatch. So it's a dysregulated immune process as well as a repair process that we are seeing. Unfortunately, we don't have access to this information in our patients because of the postmortems done. We don't have histology as yet because those have not been processed. So it's important to understand this pathological process and the host immune response, so you can target your therapies accordingly and use your armament of investigations and radiology to support you. So the radiology, as described earlier by Lakmini, plays a key role. What we have access is to the chest radiograph, which shows peripheral ground glass basal predominant opacities, which may over time change into consolidations, air bronchograms, cavitations, effusions, lymphadenopathy are unusual in COVID pneumonias. They describe this atoll sign, where we see this here. We see like atoll is island, like you see in the Maldives. You have a island which is sort of to be like ground glass changes. How do I get this slide back? Yes, and it is surrounded by area of consolidation. So this atoll sign is classically described in organizing pneumonia, which they have described now in COVID pneumonia also, a feature, atoll sign. So I'm wondering whether this is the result of organizing pneumonia setting in early, especially this fibrinous, acute fibrinous organizing pneumonia setting in early in these patients, rather than this being a sequelae of COVID itself. So the radiology will go through this septal thickening, ground glass changes, craving, and in the slide that you see there, basal predominant consolidation with air bronchograms that we would classically associate it with ARDS. Also, in these patients whom CT access is not easy, bedside ultrasound, lung ultrasound plays an important role, because some of these changes that we see in ARDS, subpleural basal consolidation, with the if you have the expertise, you can identify these patients. So this is a summary of COVID radiological changes, mostly CT, but CT is sometimes not practical and easily accessible. We have the advantage of having reviewed a lot of CTs in COVID patients, because at Mullaeriya, the IDH CT is dedicated for COVID patients only. So we have good, excellent radiology support, a husband and wife combination, who helps us a lot with the radiology. So we have a lot of experience in looking at radiology, the HRCTs in these COVID patients. And with our background of training and our expertise in interstitial lung disease, we are able to discern a lot of things, and this to influence our clinical decision-making process. So the radiology also has a chronology, and the radiological evolution is there, from ground glass to crazy craving to consolidations to atoll to recovery or death. If you recover, fibrotic changes that may persist. So day 9, day 13, when we are faced with these decisions, are we going to increase our steroids as Lakmini did in the patient with organizing pneumonia? Are we going to persist with as outpatient steroids to further manage the organizing pneumonia? Are important decisions that we have to take. So this is another thing that we saw in these patients. We saw in certain patients developing pneumomediastinum and pneumothorax. These are not patients who are mechanically ventilated, but they developed interstitial, they developed this pneumothorax. So I was wondering what is the explanation for this? And our trainees who are now in the UK, senior registrars in respiratory medicine, who are first line, who are working in big centers like Papworth with ECMO, managing ECMO and everything. We share our experiences. We are on WhatsApp groups discussing patients. They also have this, they have also seen these patients with pneumothoraces and pneumomediastinum. We see this in advanced fibrotic lung diseases where intra-alveolar rupture can occur. Alveolar rupture can occur, giving rise to an interstitial emphysema, and this air tracking to the mediastinum and to the and giving rise to pneumothoraces. So it is something that you should be mindful of, and this occurs in the non-ventilated patients also. The other thing is we don't know whether pneumocystis, which is can be a co-infection, in whom we see in patients who are immunosuppressed, developing pneumothoraces and pneumomediastinum, with a reactivation of pneumocystis jirovecii, especially in the post-transplant immunosuppressed patient, plays a role. This is again this organizing pneumonia to illustrate what they call this intra-alveolar fibrin balls. Okay, so thromboembolic disease, we should have a low threshold to suspect thromboembolism, as we saw in our patient. Usually, we don't have the luxury of a CTPA. We can at Mullaeriya, But sometimes these patients are on CPAP and high flow nasal oxygen, and transporting them becomes a bit of an issue. So we have a very low threshold to convert from prophylactic to treatment dose of enoxaparin. And then if the D-dimers are rising and we have the patient is hypoxic with a alkalotic pH CO2 washout, we will start them on treatment dose of enoxaparin. And post discharge, we will follow the usual thromboprophylaxis protocols. So our current management strategies are enoxaparin prophylactic dose and a treatment dose escalating to a treatment dose with a low threshold for PE. If the saturations are low on rare air or with supplemental oxygen, as is now standard of care, and from the data coming from the recovery trial, we would give dexamethasone 6 milligrams IV daily for 10 days or until discharge. We would give broad spectrum antibiotics, initially ceftriaxone, maybe clarithrol atypical cover, but we should guide our antibiotic choices based on procalcitonin, which is now available. It's deemed costly, but when you compare with the antibiotic cost, having serial procalcitonins and excluding bacteremic sepsis would save on a lot of costs on money, and also prevent emergence of resistant pathogens. So high flow nasal cannula oxygen, self-proning, and CPAP are some of the modalities we use. And we must be thankful to Dr. Afla, who through donations were able to get four high flow devices through his contacts to Mullaria Base Hospital. One unit costing about 1.2 million. I think one of these devices cost about 1.2 million. So we must thank Afla on behalf of all of us and our college. The fluid strategy in this patient will be euvolumic, neck nebulization, because they are taught to have thick, very viscid secretions, but I couldn't find any evidence for that. But now we don't give HCQ in patients who are hypoxemic and hospitalized. So these are the challenges we faced around day 7, day 14, and there are critical decisions that we need to make. If there is patient deterioration, oxygen demands increasing, what is the reason for this? Is this a progression of viremia? Is this cytopathic injury to the alveoli and your lung, giving rise to acute lung injury, ARDS? Is it a hyperinflammatory response, a dysregulated immune response with your inflammatory markers, your IL-6, your IL-1, and all the other cascade of inflammatory markers going up? Is it secondary sepsis, bacterial sepsis? Is it fungal? Is aspergillus playing a part? Are these deterioration due to thromboembolic events? Next, we also have to think of this organizing pneumonia. This where we saw radiological changes consistent with organizing pneumonia. In fact, some people argue that the terms that we use, happy hypoxemic patient, the patient is hypoxemic, but work of breathing is not increased. The same terms we have used for this acute organizing pneumonia. So are we okay with the steroid dose of 6 milligrams dexamethasone? Should we escalate our steroid doses to higher doses in such patients? So these are the decisions that we are faced with. So multi-organ failure can occur as a result of any of these and give rise to cardiac and renal injury. So a chest X-ray that looks worsening, a chest X-ray does that look worsening does not merely mean that there is secondary bacterial sepsis and you don't need to escalate your antibiotics unless there are supportive evidence. In this regard, procalcitonin plays a vital role. If your procalcitonin is negative, you can safely feel that bacteremic sepsis is very unlikely. CRP rises can be due to hyperimmune responses and other inflammatory things. The X-ray changes can occur due to fluid overload, which as a result of AKI or cardiac injury. Your pro-BNPs, BNPs, your cardiac troponins, and your renal parameters will help you understand this. It is a multidisciplinary process where each of our expertise are come into play, and we have a process of multidisciplinary decision making. So in whom should we give tocilizumab? This is much debated, and I think later on you'll hear a little bit about the data on this and the studies when Afla speaks. When Afla speaks. So sometimes in a patient who is deteriorating, oxygen demand increasing, X-ray worsening, bedside ultrasound if you can, showing bilateral B lines. There's no evidence of fluid overload, no evidence of injury. Procalcitonin is normal, no evidence of sepsis, no evidence of thromboembolic events. Your D-dimers are not very high, or CTPA, if you have the luxury of having it, it's negative, then it's likely to be hyperimmune. So what characterizes this? There is a marked inflammatory response. Your D-dimers should rise. Your CRP, the cutoffs that the recovery data says is 75 milligrams. Is considered hyperinflammatory. Your serum ferritin, we do the serum ferritin, but the reports don't arrive in time, and we don't have the luxury of doing serial serum ferritins to monitor this hyperinflammatory response. But they are usually in their thousands, and your LDH also start rising. If you have your clinical suspicion, your radiological support, and your blood gas and other parameters, and supported by one or two of these biochemical parameters, we would consider such a patient having a cytokine storm and providing IL-6 receptor blockers, tocilizumab, which is the drug available here. There are other drugs, but not available here. There is IL-6 levels you can estimate. There is a machine at IDH, but currently due to other factors like calibration and things, the machine is not functional, but IL-6 levels are not usually done and not needed in these patients. So the data on tocilizumab is a little bit cloudy or controversial. Initial data did not show very good outcomes, but this may be due to the fact that these patients were given tocilizumab as a monotherapy and they didn't have the steroids. So the more recent studies, right, REMCAP and other recovery studies, steroids have become, dexamethasone has become the standard of care. So as a result, these patients get a combination of the steroid plus the tocilizumab. So in such studies and more recent studies, they have showed a better outcome in these patients. Again, in the mechanically ventilated patient, we talk about these two phenotypes, the L type, with low elastance, high compliance, and the H type, the high elastance, low compliance patients. The low elastance patients have more VQ mismatch, intraalveolar shunting, as mentioned before, maybe due to microthrombi, maybe due to intraalveolar buds, and maybe that's why this low elastance group who are hypoxemic. Whereas the high elastance, they have a dry lung and their fluid strategies are different, where you have to have a euvolemic fluid strategy. Then the high elastance types, which are more ARDS, which are wet lungs, which the chest CT, as I mentioned before, and your ultrasound will show subpleural basal consolidations, are more lungs which you will try your recruitment maneuvers like proning, and you're using your PEEP to recruit consolidated lung. So moving on from the acute things, then we, as I mentioned before, and as illustrated in the cases, we move on to long COVID or post-COVID sequelae. Those about 10% will have post-COVID sequelae or ongoing symptoms of long COVID. This is irrespective of the fact that these patients have had intensive care or HDU visits, or intensive care, being in intensive care units. So this may vary from shortness of breath to pyrometric dysfunction, fatigue, and all, to severe significant sequelae of ongoing pulmonary, new or ongoing pulmonary embolic disease, thromboembolic pulmonary hypertension, to interstitial lung disease, which may vary from organizing pneumonia, as was illustrated in the cases, to interstitial pathology, which was like a non-specific interstitial pneumonia. So I won't go through these algorithms. These are BTS which proposes these algorithms. Some patients will have mild disease, will have remote consultations. I'm told that they are given a pulse oximeter at home to monitor their oxygen saturation. If the oxygen saturation is declined, they are asked to immediately report. And such patients may go through a diagnostic workup, including D-dimers, CTPA, ferritins, to see whether there is high inflammation still going on. And they will have relevant imaging like CTPAs and high resolution CT scans. So this I mentioned. So pulmonary vascular disease and pulmonary hypertension, as I said, this is a very prothrombotic disease in which pulmonary embolism and as a result pulmonary hypertension, and due to vascular endothelial dysregulation, pulmonary hypertension can occur. In some centers, in these patients who are in the intensive care units, they have given IV prostacyclin or nebulized prostacyclin to treat this pulmonary hypertension, but I couldn't find anything pertaining to this in my reading as of yet. But even in UK between centers, there is difference in protocols. So this organizing pneumonia that you saw is also, we have seen in the post-influenza, but we are seeing much more of them now and much earlier. just a few minutes ago. So these are the features of organizing pneumonia. So you have to make a distinction from resolving COVID. When you look at this HRCT, in resolving COVID, you'd see more ground glass changes, reticulation and all. But in organizing pneumonia, you are seeing very thick parenchymal bands, what we call arcades, pleural-based arcades, and this atoll signs. So it can have organizing pneumonia-like feature or a more fibrotic disease. So there will be a significant disease burden. Now we have had 100,000 people who have had COVID. About 10% of them will have symptoms of long COVID, not only lung, neurological, cardiac, renal. So we are looking at public health or problem also, and a problem where healthcare systems may get inundated with this. So I'm not going to talk about non-pulmonary complications. This briefly a slide on that. But these are also, and of course we must keep in mind that the psychological consequences of this are also there. So people need reassuring, people feel scared, and they lose self-confidence. So we need to pay attention to the psychological aspect also. Just a few minutes ago, there was a patient I saw. She has been in a private hospital about 4 months, 1 month back with respiratory tract symptoms. She had delivered 4 months ago. In this hospital, she hasn't had a PCR done, or she hasn't had antigen done. She has been managed for a respiratory tract infection and discharged because of persistent breathlessness. She came to the private sector. She had an X-ray which showed ground glass changes. I did a CT, and the CT showed organizing pneumonia changes. And when I did the COVID antibody is positive in a high titer. So there are patients who will crop up like that, and you have to have a low threshold to suspect this. So in conclusion, pulmonary manifestations of COVID-19 can show a variety of changes. And as you saw, the disease is evolving, the challenges are evolving, and we have to be on the alert all the time. The things that I would like to discuss with the other people who are managing COVID is the dexamethasone dose that we are giving of 6 milligrams daily IV, enough in these patients on whom we are suspecting organizing pneumonia. Recently, there was SR who returned, my SR who returned from the UK. He said if they are seeing changes of organizing pneumonia, they double the dexamethasone dose. They increase it to 18 milligrams or of dexamethasone. So should we increase the steroid dose? Should we look more carefully at tocilizumab? These are the things that we have to discuss among ourselves in our strategies of managing these patients. So, and also I feel that death reviews are important. We have had 618 plus deaths, but we haven't had a death review where the relevant experts sit down and discuss this. And it's important, I feel, that we have access to histology to know how our patients behave. Are our patients more prothrombotic? Are our patients more ARDS, acute lung injury patients? How does other organ system damage play a role? So it's important that we have access to this information. So I think we'll have a time for discussion. So I'll conclude my talk with this. It's my pleasant task to call Dr. Afla Sadikin, consultant respiratory physician, NHSL and Central Chest Clinic, my colleague, to take us to the next segment of this session.
Thank you very much, sir, for that kind introduction. First of all, I want to thank Sri Lanka Medical Association and College of Pulmonology Sri Lanka for giving me the opportunity. So this is more or less like a scientific analysis of whatever we have discussed over the last few minutes about COVID pneumonia and the pulmonary sequelae. So though as a tradition, we just go through the MCQs, and I'm not going to take the MCQs for you all to answer the question and to get how much we got correct and how many we got wrong. So basically there are 4 MCQs, and but going to take those responses in detail on a scientific explanation. Right. So first question, which is not a feature of cytokine syndrome in COVID pneumonia? And A, increased ferritin levels, B, leukocytosis, C, fever, D, elevated IL-6 level, E, elevated LDH. Right. So my discussion or the is on some of the things we have discussed before, just to re-emphasize how much we have gathered and how much we should focus, how much we should focus on in the COVID patients management in the future. So we all heard about these 3 stages, that is the early infection, pulmonary phase, and hyperinflammation phase. In fact, what we see here is that is commonly in our setup is the pulmonary phase and hyperinflammation phase, which can be overlapped and may be difficult to differentiate. However, the presence of clinical symptoms of shortness of breath with evidence of hypoxia in critical ill patients, checking with the PF ratio is quite important to decide the treatment modality. So obviously your radiology and your blood levels to exclude infection, secondary infection, is quite important to decide on the treatment modality. And we must never forget that the hyperinflammation is taken a big area in the COVID pneumonia. But remember, the hyperinflammation is not something new for us, because we all know that the HLH or hemophagocytic lymphohistiocytosis is something we have come across in some of those infections like TB and also rheumatic diseases. But here in COVID pneumonia, it has a classic descriptive way of defining the hyperinflammation in COVID pneumonia. So we all know that if you take the HLH criteria for symptoms, signs, and investigative biomarkers for hyperinflammation, the COVID pneumonia hyperinflammation is something characterized by having fever and anemia, thrombocytopenia, neutropenia, hyperfibrinogenemia, also hyperferritinemia. If the presence of transaminase, elevated transaminase, is something which they have described, but still the evidences are not that conclusive on that. If you take the criteria in COVID pneumonia hyperinflammation, they have put up the fever as many as more than 38 Celsius. Also, macrophage activation is defined by high serum ferritin more than 700. The hematological dysfunction, which is very important, especially in the initial phase, where the neutrophil and lymphocyte ratio is more than 10, and also low platelets. Sorry. Also, presence of coagulopathy, like Amita sir said, that the higher D-dimer concentration is also another indirect way of assessment of hyperinflammation. And if you can demonstrate cytokinemia where the IL-6 levels more than 15 is a good biomarker to show the hyperinflammation in COVID-19. So Manson and the group, they wanted to minimize or to make it very easy to come down to define the hyperinflammation in COVID-19. So in their cohort of studies, when the patients, they came with evidence of hyperinflammation on admission, so also non-hyperinflammation on the other patients who were admitted with pneumonia, they came out with a plan to say that the hyperinflammation on CRP level is more than 150, or within 2 hours the baseline should go up by 50, and presence of high ferritin for more than 1500 and IL-6 levels more than 15. However, this cohort of patients had their overlapping features with secondary bacterial infection, and also those patients, some were admitted directly to the ICU for high oxygen demand. So what we have learned here now is, when it comes to cytokine syndrome in pneumonia, increased ferritin levels, fever, elevated IL-6 level, and elevated LDH level is quite, it's established, but not leukocytosis. It is neutrophil versus lymphocyte ratio more than 10. So we'll discuss about drugs when it comes to COVID pneumonia treatment. So we all know that the use of dexamethasone, HCQ, tocilizumab, GM-CSF, anakinra is another IL-1 antagonist. So what is the drug which is not useful in COVID pneumonia? So just to go again in detail of treatment modalities, over the last 1.5 years or so, there had been a lot of debates all over the world about finding ideal drug for COVID pneumonia. So there had been a lot of speculation on antibiotics like azithromycin, HCQ, and also use of later use of dexamethasone and enoxaparin or anticoagulation. So, however, the recovery trial is the one which really came up in a very good, well-designed study to include all those antivirals, dexamethasone, hydroxychloroquine, and azithromycin to look at the outcomes, especially the primary endpoints of all-cause death and duration of hospitalization and ventilation, need for ventilation, and need for renal replacement therapy as a secondary endpoints. So this study basically showed that dexamethasone has been a very important drug for the COVID pneumonia management, and now it has become the standard of care approach. So basically, they have found that patients who were on invasive mechanical ventilation, also who needed oxygen, had a good response compared to the usual care, and even all patients, there was no supportive evidence to use dexamethasone in patients who did not receive oxygen, showed still a good response to bring down the hospitalization and duration of the hospitalization, also to requirement of mechanical ventilation. Now, so in those 2,104 patients, they found that 1/3 of those ventilated patients, death can be prevented by dexamethasone. So it's a big achievement, or within very short time, we have achieved to at least a drug for standard of care. So what about hydroxychloroquine? We all know that there was a big hype at the outset of onset of this COVID pneumonia pandemic. And also I know that there are some centers still, they are quite convinced that use of hydroxychloroquine is for the COVID pneumonia management. However, in the recovery trial, it is clearly showed out of 1,542 patients who received HCQ, showed that no clinical benefit. So we can safely say it has no clinical benefit using in COVID pneumonia. Now, as Amita sir said, interleukin-C receptor antagonist, or this tocilizumab, was a drug which came with a big hype initially, but however there had been a lot of confusing results initially, but later the evidence came quite promising for those timely used interleukin-6 receptor, or the tocilizumab, for those critically ill patients who needed high flow nasal oxygen, or who needed non-invasive mechanical ventilation. So they have, in the REMAP-CAP trial, they clearly showed that those patients basically receiving organ support, especially on the in terms of oxygen, they did really well, including their survival. But if you go back to the previous studies, which was done as an IMPACTA trial, and even though they showed that there was no overall all-cause mortality by day 28, there had been no difference, but still it showed that requiring mechanical ventilation and also medium time to clinical failure up in day 28 is significantly reduced with the use of tocilizumab. And this top trial using 3,924 patients after giving 433 patients with tocilizumab, it has showed that 30-day mortality was reduced in tocilizumab patients, that is 27% compared to 37% in non-tocilizumab. I think it's quite significant in those critically ill patients. However, all those overlapping or non-convincing data could be all because of the unmeasured confounding factors. This QUACTA study had that issue. In fact, they found that in that study that there was no difference between tocilizumab and placebo. Probably it's interesting, it was done by the Roche, was sponsored by the Roche company, where the tocilizumab was, they are the people who originally produced the tocilizumab. And in that study itself initially showed there is no difference between tocilizumab and placebo. However, it is important to understand all these later earlier studies did not have dexamethasone, or those patients had a number of patients used dexamethasone were like 18%, 32%. But if you go back to revamp CAP's study, in that 88% of the patients had dexamethasone as the standard of care. So their survival benefit showed, or the positive results showed with tocilizumab because of probably use of dexamethasone. What about GM-CSF? So I know it's something very challenging and set up giving GM-CSF in certain patients. But when you manage severe COVID pneumonia who need mechanical ventilation, and sometimes you are really, as a clinician, you are really helpless, and you are really looking forward for something to give to improve the oxygenation, because otherwise patient is perfectly all right, you cannot improve the oxygenation, patient is just drowning without oxygen. So they, in this single center prospective cohort study, they found that out of 13 patients, all of them have got fast improvement and without progression to death. So I think it's something we will be looking forward in the near future as well. So anakinra has been a drug, or this IL-1 blocker is been a drug used by the rheumatologists and in many rheumatological conditions. And in the small study which was published in Lancet has shown a good promising results, though it's a small prospective study with a prospective data, but still it has shown a good results for mortality reduction. So now we know that when it comes to severe COVID pneumonia management, use of dexamethasone, tocilizumab, GM-CSF, and anakinra probably to some extent very useful. But we are now very certain that use of HCQ has no place. So just we'll go through the radiological features. So we saw a lot of X-rays, a lot of HRCT films. So just to recap and to consolidate our knowledge on X-rays and HRCT. So what are the common features? What is the feature which we will not usually see in COVID pneumonia? Is it peripheral zonal airspace consolidation opacities along with along the periphery of both lungs in the chest X-ray, or is it diffuse ground glass opacities in the HRCT, crazy PV pattern in HRCT, parenchymal bands in HRCT, and bilateral pleural effusion? I think the answer is quite straightforward. What we see usually in chest X-rays in pneumonia patients where you get bilateral, probably sometime asymmetrical, basal predominance, peripheral, subpleural, ground glass opacification with sometimes with consolidation. So this asymmetrical appearance is quite common in COVID pneumonia. When it comes to HRCT, yes, we saw so many HRCTs. We heard from Amita sir about the HRCT findings. Yes, what you usually see is diffuse ground glass. There is no certain pattern for this ground glass distribution, but sometimes it's a perilobular distribution is described. In addition to that, we see peripheral organizing band-like areas, maybe with the features of crazy paving pattern. So we all see all these things. So what we don't see is the bilateral pleural effusion so commonly. If you see bilateral pleural effusion, we should think of the other possibilities like fluid overload or even cardiac involvement with COVID pneumonia. So the last question, which is not a feature after recovery of severe COVID pneumonia. So we see a lot of COVID pneumonia patients, and but we are not fully aware what can happen to these patients even after the recovery. So is it pulmonary embolism, long COVID syndrome, lung fibrosis, DLCO reduction, normal 6-minute walking test? Right, just to go through, basically pulmonary embolism or thrombotic phenomena is very well described, and they have found up to 5 to 30% will develop thrombosis. And microthrombosis is the key mediator when it comes to COVID pneumonia, and also end organ damage, including acute kidney injury. So it poses a major morbidity and mortality. So the study, the multi-platform RCT, that is a collaboration between 3 trial platforms, had found that the thrombotic events are still possible, even those patients who were anticoagulated for therapeutic anticoagulation, or even as a thromboprophylaxis, even moderate as well as the severe cases. So still these patients can have microthrombosis and thromboembolism. So it can be just the pulmonary thromboembolism, what we heard from Amit sir, that is about, and also leading into pulmonary hypertension. So long COVID syndrome, we heard about long COVID syndrome, and which is by definition, when you have signs and symptoms which last for more than 4 weeks after recovery of COVID-19 pneumonia. So you can put into 2 categories or 2 stages. You can have ongoing symptoms that last for 4 to 12 weeks from the onset of your symptoms of COVID pneumonia, or you can have after recovery where the symptoms last for more than 12 weeks, which cannot be explained by any other diagnosis. Now, when it comes to symptoms, it is not purely respiratory symptoms. We have to remember that. So what we are worried is the respiratory symptoms where development of non-specific interstitial pneumonia or organizing pneumonia, and probably thromboembolic phenomena also. So the European Respiratory Journal, which was published recently, have shown that in that study, they have shown that that the patients who did not have any previous existing interstitial lung disease have developed 15 to 50% of dropping of DLCO in these patients. It's a very significant number. So after 1 to 3 months following COVID pneumonia. So remember that dropping of DLCO is maybe something we have to make ourselves aware that there is an interstitial process going in these patients where patient needs intensive investigations and treatment early as possible. However, when you do the DLCO too early, that means within 3 months, your functional assessment, when you want to assess the functional capacity, so basically it may overestimate whatever the disease impact on the lungs. So you must not do DLCO within 3 months, and must always look for any dropping of DLCO after 3 months. And the Swiss observational study after COVID pneumonia, in that big study, they showed that patients who have recovered after severe and critical disease after COVID pneumonia has a significant reduction of DLCO on predicted values, also reduce 6-minute walking distance. And also they have obvious exercise reduction, exercise-induced hypoxemia. So basically what we know here is these patients after recovery of severe COVID pneumonia, they can still have pulmonary embolism, they can have long COVID syndrome, they can develop into lung fibrosis, and also DLC reduction. But not, a 6-minute walk test is not going to be normal within that 4 months. Thank you. So this is, I'm going to bring this last 2 slides to recall what Amita sir said. But remember, the thorax with the BTS, they have published these 2 protocols, especially people, even for the GPs to follow up, that even with mild to moderate symptoms, they can still have after 12 weeks their X-ray changes, and at what point we are going to do the pulmonary function test, and even including high resolution CT scan and CTPS if you are suspecting ongoing symptoms. And also especially patients who are recovering from coming from out of the ICU or HDU, their protocol even looking for persistent symptoms through the same investigation, but at a different level, including the respiratory physician or the ILD specialist. Thank you.
Yeah, if I may ask you that now when the patients are being treated in ICU, you know that they are with symptoms, they need investigations, and we all are geared to plan investigations for these patients. Is there a place for routine screening of asymptomatic patients for these complications?
Not really. But most of the asymptomatic patients, what they would do is look for respiratory symptoms, breathing difficulties, breathlessness. What they do in other countries, they give a pulse oximeter and to check their resting saturation and saturation on exertion. Because this perception of dyspnea, as we said, this happy hypoxic patient may manifest late. So it may be a remote consultation. I'm talking about a developed setting where remote consultations may happen. In such settings, there may be a remote consultation. If there's a drop in saturation and all, they would be asked to come to the hospital. And as I said before, these long COVID or post-COVID patients who keep turning up, who have been asymptomatic during quarantine and other period times, but then they are coming later on 4 weeks to 12 weeks without persistent symptoms, but with new symptoms, ranging from fatigue, chronic fatigue, to neuropsychiatric disturbances, to respiratory and other manifestations. So I would say that initially screening with investigations would not be cost effective. Afla, would you like to add something?
I think why it is not practical is the large number of patients. If everybody turns up to for medical attention, because already they have gone through that anxious period of though they were asymptomatic. So I think, like Amrita said, it's not going to be cost effective to screen everybody.
The other clarification that I had was that the story that was related by Dr. Amita Fernando with regard to a patient who had infection, we thought about 4 months ago, and now appearing with the respiratory manifestations. Could we imagine that we're not doing checking COVID in this country for a person who has had a respiratory infection 4 months ago?
This patient really, she was symptomatic. She had respiratory symptoms. In fact, she was hospitalized, in fact, for I think about 2 or 3 days and treated for lower respiratory tract infection. There was X-ray also done at that time. I can't remember the blood count, lymphopenia and things. But then when I asked the patient whether she had an antigen test, or which would happen anyway here now, yes, whether I agree with you, whether it's acceptable at this time, because they are infectious and they have to be quarantined, and they can have serious consequences also from themselves.
That's right. Yes. And what is the place for ACI in COVID management?
Initially, they were saying that angioreceptor receptor site is where the virus gains entry into the cells. So there was things about withholding people who are on ACE inhibitors, withholding ACE inhibitors, but now there's no evidence for that, and they don't advise on withholding the ACE receptor blockers as a therapeutic modality or initial thing. I don't think there's any data to support use of this. There are other things like ivermectin, which is anti-helminthic, which is cheap, which is available here in the early stages of disease, where patients were not hypoxemic, they were mildly symptomatic. We have used ivermectin 12 BD and 6 milligrams daily for 5 days. But I mean, I don't know whether there's any randomized control data on that.
The saturation target in COVID management.
The saturation target, resting saturation of 94. And if on supplemental oxygen, that is 4 liters or 40% oxygen, nasal prongs or face mask. If the saturation is not maintained above 94, then we would go for dexamethasone, enoxaparin, high-flow nasal oxygen, and may have to escalate to CPAP or NIV.
Right. So I could open for any questions from the audience.
I think if I may comment, it would be nice if we could have a centralized multidisciplinary, I have been telling Madam also, a team of critical care specialists, physicians, intensivists, respiratory physicians, radiologists, with support from microbiology, hematology, and other fields, and renal, neurological where relevant, where we have a centralized team of experts where we can deal with these issues and come when they come, because it's a learning experience, and also pooling resources, and also utilizing our resources maximally. So I think we have a intercollegiate guideline committee, SLMA as a committee. That would be a good if that initiative can be taken, Madam.
Thanks. Thank you very much, Amit. I think that we were able to go through one of the most productive, most informative, up-to-date account on the management of COVID pneumonia and pulmonary sequelae. They were able to address the acute management as well as the features of long COVID. And generally, I think that many of us are not experienced in managing COVID patients, because for most of us, as the PCR becomes positive, it's a sort of matter of transferring the patient to the COVID center. So that beyond that, we thought that it's the infection specialist that who would manage patients. But now we understand how much of multidisciplinary involvement and how much of a contribution that has to be there from the pulmonology side, and the complexities involved. And the need to give care for many of us. The impression was that it's just the symptomatic management, but I mean, what more is involved beyond that symptomatic management, how closer monitoring is needed for these patients who are critically ill. So I think that it was a sort of a very comprehensive account that we got with regard to management of COVID and the complications. And I know that you had to spend a lot of your personal time as well as the effort in making it a reality, making this the whole panel discussion a reality today. So on behalf of the Sri Lanka Medical Association, I'm very grateful and thankful to the College of Pulmonologists for this, for the contribution that was made to make this academic program a great success. From our side, I'm thankful to Dr. Achala Balasurya, who liaises on behalf of the Sri Lanka Medical Association. So keeping with our traditions, let me show our appreciation of the Sri Lanka Medical Association. So that brings to an end of our monthly clinical meeting. Thank you very much for all who stayed with us online and in audience for joining with us this meeting. Thank you very much.